Thank you for joining us today for another AHA Leadership Dialogue discussion. It's great to be with you. I'm Joanne Conroy, CEO and President of Dartmouth Health and the current chair of the American Hospital Association Board of Trustees. You can tell that I have some laryngitis, but I am delighted that I don't have to do a lot of the talking because I'm going to be joined by Dr. Steve Diaz, who's Chief Medical Officer of MaineGeneral Health. MaineGeneral Health is a comprehensive nonprofit health system located in Augusta, Maine. And in addition to serving as Chief Medical Officer, Steve is an emergency medicine physician by training and is deeply involved in many of MaineGeneral's healthcare quality and safety initiatives. All hospitals and health systems strive to deliver safe, high-quality care to every patient we serve. For decades now, we've made innovative changes to drive improvement in outcomes, and we know that dramatic improvements have been made. Earlier this month, the AHA released a new report showing that hospital and health system performance on key patient safety and quality measures was better in the first quarter of 2024 than it was before the COVID-19 pandemic, and that hospitals made these improvements while caring for patients with more significant healthcare needs. We also know that hospitals and health systems can't get complacent. We must continuously work to advance safety and quality. Our ongoing collaboration with each other and shared innovation in research and clinical operations continue to drive safety forward. Last year, the AHA launched a national initiative to reaffirm our leadership in commitment to patient safety. AHA's Patient Safety Initiative is guided by a clinical advisory panel and a strategic advisory group. They focus on reducing patient harms, increasing health equity, and improving public trust. But before we jump into our discussion and my questions, Steve, our audience really wants to know about our speakers. So can you share some information about your background and how you got to MaineGeneral and how that's affected your approach to patient safety?
Oh, thank you, Joanne. Glad to join you today. I started in healthcare prior to medical school. I was in EMS, worked in Sacramento ambulance, and decided I would take the plunge going to medical school. And I decided, growing up in California, I decided to have an East Coast experience. I went to Cornell, New York Hospital, thinking after that I'd go back to California. I was somewhat wayward, took a year off and taught there, and then decided to do family medicine training to start with, and would go to a rural area again to grow up and figure out what I wanted to do for my life. So I said that I would go to Maine for 3 years, 31 years ago, and then finished my training, and then went into emergency medicine and grandfathered into that a long time ago, and then became involved in disaster, EMS, and emergency medicine on my way to becoming an administrator for MaineGeneral. It's interesting. I think prior to medical school, having that EMS experience was key. We work in teams. We've always thought we worked in teams. We really strive to work in teams. And I would say the thing that I focused on at MaineGeneral is flattening the hierarchy and moving things so that we're all taking care of patients in a coordinated fashion rather than everybody having a different care plan, if you will, which can sow confusion. So my background is I was not expecting to become a doctor when I was younger. I was very happy with what I was doing. But I took the plunge and very happy I did what I did. And I did not mean to stay in Maine, but again, could not be happier.
So, Steve, you and I share an affection for the state of Maine. My family grew up in rural Maine. But why patient safety? Because emergency medicine, you can take many paths after training in that specialty. But why was safety such a passion for you?
Safety is such a passion because in emergency medicine, the times that we get involved in the high acuity situations is not as common as taking care of ambulatory sensitive conditions or even intermediate medical conditions. Because of that, when we do our critical care in emergency medicine, it's not the most common thing we do. whether it's central lines intubations, using vasoactive drugs, or other things that are very aggressive, you have to be sure that the whole team is ready for that. Today, of course, we all have care bundles and team practice in STEMI care, sepsis, stroke, and trauma, all the time-sensitive conditions, but that was not the way it was 30 years ago. And so one of the roles I had early in my career here in Maine was I was the medical director for Maine Emergency Medical Services, so the state medical director, and we worked to have state protocols for STEMI care, for ER to cath lab. We worked to have state protocols for stroke care. We had, prior to my time there, we had state protocols for trauma care. And now sepsis care, again, having state protocols or state initiatives that it starts with EMS, will hopefully change that curve as well. So it appealed to me because you have to plan for it. You have to have teamwork. You have to have be critical of yourselves, both individually and as a team, in order to improve the care and the outcomes of the patients we serve. So that's why in emergency medicine it called to me. We have time-sensitive conditions where you have to have a playbook that everybody understands before the patient arrives.
Now, you trained in a rural area. That's got to be different than delivering emergency care in an urban area. What are the challenges that you've run into in rural Maine, where most of the hospitals are critical access hospitals, except for a handful of quaternary care facilities?
I think the biggest issue in rural emergency medicine care is you don't have the consultants at your fingertips, if you will, whether it's trauma, stroke, heart attacks, or STEMIs. You might have to be creative on how you get those patients the care they need and find your consultants. I think in many ways I was fortunate that I was a EMS medical director for Maine early on, because I met a lot of people across all the systems. And again, the goal here was to have a system of care so that no matter where you went, you'd have the same care. So let me give you an example. When I was a young ER doctor and I had somebody with a ST elevation, myocardial infarction, or a heart attack in front of me, the referral centers with cath labs who did interventional cardiology had 3 different protocols. And so I had different color folders, we all did, in our ER, depending which tertiary care center they chose. And so, and heaven forbid that you pick the wrong folder color and someone changed their mind, or there wasn't bed availability because the receiving hospital, again, they just, the nuances were not significant, but they were nuances. And so we worked to have that really ironed out. And I think that is the same discussion you have with stroke care, although that has really been helped by other entities having some standardized protocols. But then having the consultants know who you are and where you call them. Interestingly enough, my preferred shift was the weekend to overnight shifts in the ER. It just seemed to be a shift that went by quickly, lots of teamwork, no offense, less suits around, but it also made it so that I really had to know my consultants and know where I was going. And in rural emergency medicine, rural states, or rural healthcare in general, again, you have to know where you're going to go because you might not have a lot of things in-house. And that was true 30 years ago, and it's still true today, making it more important that we know our networks of care and our consultants.
We know that having more regulations or rules around safety doesn't actually give us the outcomes we want. And there are other things we have to work on. And we've talked a lot about the culture of safety. Let's actually move out of the emergency room into your facility, because you are in charge of actually creating that culture of safety across the organization. Talk a little bit about what are the most impactful things that you have done. And do you have some success stories and maybe some things that didn't go as well?
Yes. So 17 years ago is when I started my role in administration at MaineGeneral. And the CEO then let me know that there were 2 things he wanted me to concentrate on. He wanted me to flatten the hierarchy, and he wanted me to make sure that a physician's behaviors were held to the same standard as everybody else on the staff. And so that's what my focus has been. And that is how we created our culture of safety and quality. So we flattened the hierarchy. We have awards all the time for people who speak up, anybody who speaks up. That's not the right antibiotic. The timing is not correct. Are we sure we're on the right side? I mean, all those things that we take for granted. We celebrate anybody who comes up with either preventing a miss or a near miss, or it's just speaking up and feeling comfortable with it. So it's really a night and day from the way it was decades ago. And the other part is the team sport part of it. And I can give you more examples there. So I think many hospitals during COVID had higher rates of travelers or people who came in who were hoping to fill a gap, but weren't really part of your core team. And I call it our pit crews. And because the pit crews didn't know each other as well, we had gaps in our standardization and our ability to deliver quality care. Indwelling urinary catheters, we are very strict, and it's really driven by teams, not just the physician saying who can have one and how long does it stay in, and how long or who do I need to in order to take one out. And we've really moved quickly and far in having nursing help drive that question us and push back on us and get those out. And when we don't have the pit crews, the people who are part of the everyday team, they may not feel comfortable speaking up and saying, let's do something proactive here. And that same paradigm follows with central or midlines, so catheters that are more indwelling can cause more problems. Let's standardize how we do that and make sure that our teams are taking ownership and not just the person who put it in or thinks that somebody needs one. And you try to push that out as far as you can. And it's not always a success. So I said early on, I took on STEMIs when I was Maine EMS medical director, and we were successful in having statewide protocols. I was not as successful as with stroke, and including with MaineGeneral. It's been fits and starts. Part of it is the evolution of thrombolytics for stroke and catheter-based therapies, and it doesn't seem to be as directive as the cardiologists on treatment for heart attacks. And so even because of that, we took a run at this many, many times to try to have statewide input, and it just seemed to fall apart. I would say now it's much better given that the Joint Commission, American Hospital Association, American Heart Association, and others are in that space because it helps you find a true north, if you will. But some of these team-based, flatten the hierarchy, evolutionary goals do take years. And so that I think over time, the one thing I've learned is when I approach these projects, I approach it as I'm approaching somebody with tobacco cessation in front of me. Typically, you have to have that conversation 7 or 8 times before even the first step is taken. But it doesn't mean that you shouldn't have it 7 or 8 times. You have to keep tilting at windmills, keeping your vigilance, keep trying to find your true north as you do this work, knowing that it won't be a success each and every time.
So, Steve, how do you know if you're making a difference? How do you measure the culture of safety?
I think the way you measure the outcomes you need a couple different ways to look at it. We all do surveys to see if our team really does speak up, and you should benchmark against yourself and nationally, and that gives you sort of a flavor of it. I like to think about it as the number of people who come to me who are not physicians. So as I said, I've been here at MaineGeneral for over 30 years. Many people know me. If for some reason I find something out and they didn't come to me, I take that as a miss, and I try to figure out what can we do to be more open. Outcomes, you can look at your morbidity mortality numbers, which we all do, and I think those are good. And the other way I look at it, and although people think I'm crazy, I think if you find that your sentinel event and near misses, which we call significant event numbers, are going up, that is a good thing. It's good to have people telling you where you think you can do better and looking at processes. We do all different types of quality reviews. We'd like to have them fed to us and not be hunting for them. So to me, a win is when we have plenty of people stepping up and letting us know that they'd like us to review something. And as I said, people think I'm crazy. Shouldn't you be looking to not have near misses and sentinel events? And I said, that'd be ideal. But you look at the FAA, they did better where people reported more in order to improve their systems.
Yeah. So talk about your reporting system, because we all struggle with using safety reporting systems appropriately, because some of it doesn't actually fall under safety. It's professionalism, or it's just like behaviors that need to be addressed. And I think that is like one of the toughest jobs for chief medical officers is actually managing that perception about behaviors and professionalism across the organization and getting people to have difficult conversations, but also making sure that you solicit behaviors that actually lead to safety events. How do you guys look at that at MaineGeneral?
Yeah, it's like it's like you read my inbox this morning. So where that there's a Venn diagram, right? There's a quality issue where maybe something did go wrong or wasn't near miss and it was a team related issue. Maybe one person's behavior made it more of an issue versus an ongoing issue with maybe one person who always seems to be in that category, always seems to be in the mix, and people have a hard time addressing them. And they do overlap, but they're different. So if there's one event and you think someone didn't follow the protocol, didn't do the checklist, and you unroof that, and there's maybe more to it, through your RCA or failure mode event analysis, however you want to approach it, you will address that. But the behavior is different. And actually, in our shop, we call it having coffee with me, having coffee with Steve. So we have senior medical directors who help address this as well, try to take a stab at talking to somebody, trying to figure out how we support them, being direct. We no longer use the thing of, say something nice, then be direct, and end something nice. That doesn't really do it. You just need to have the conversation bluntly, yet professionally, and then follow up on an ongoing basis. And so when I started doing that, 17 years ago, I was a shop of one. And so it was Coffee with Steve. We also have a group psychology practice who caters to medical professionals here in Maine, not associated with any of the governmental agencies, that we also use to help our med staff get some support, whether it's behavioral or otherwise. And again, we put them in that program if they start hitting that professional behavioral radar as well. The outcome of that is we've had some successes, but I'll be honest, a lot of times it's hard to change someone's behavior, their personality, the way that they interact. And if for some reason it is not a good fit, we have that blunt conversation, because we really want our team to know that we walk the walk, that if we say we're going to hold people to this standard, we follow through no matter what. And that is what we do. I once mentioned what I just told you to a Joint Commissioner surveyor years ago, and talking about how we followed through and how we made sure that even behaviors were addressed the same as other issues. And he wanted to know who I thought I was, and I think I was the Cleveland Clinic. And I said, no, but when people come here, they know what they're getting. And we've had many people who've joined us who say, boy, you really are what you say, which to me is showing that we're being successful in spreading our culture. Because the other part of it is, although it's hard to recruit physicians and other medical staff, it's also hard to recruit nurses, respiratory therapists, occupational therapists. All the professions need to know this is a place where we support your professional work and you as a person. So we take it very, very seriously.
Yeah, we do know that the sense of working in a safe environment is actually really important to professionals and can be a major factor in the retention of those individuals over the length of their career. So it's much more important than probably people appreciate in someone's sense of belonging to an organization.
Correct.
So, there's a lot of conversation about AI. Is AI going to improve safety, do you think? Or is it going to jeopardize it? I know that you probably had some conversations about what the impact will be on MaineGeneral.
It's funny when you talk about AI and or even machine language, people have ideas of how it'll, I think of 2001 Space Odyssey, it'll become HAL, the computer taking over everything, or Star Trek with the little device. I don't think that's how I see AI helping us. We spend a lot of time outside of the diagnostic and patient-facing time to get people on a care plan, talking about things over and over again in order to help them. And I think that's where AI could help us. If you have somebody getting a procedure or going on chemotherapy or other complex medical conditions, informed consent to ongoing education could be a boon for AI that identifies, people with heart failure and which class they're in and what they need as education. AI could say, well, hold on. Once you're done with them in the office, you can send them this, or they'll be identified by AI to receive these education, either online, print, depending on how they learn best. And it's always available to them, and we'll check in with them. It sounds like a little bit perhaps of care management, but it's even beyond that, because it'll speak to them in a way, and you can test them so they get the information the best way they get it. Right now, all those things are done by people. If it's not the physician, it's the NP or PA, or it's the nurse or the care manager, and we're all happy to do it, but none of us have that conversation once. And oncology is my favorite example of this. If you see an oncologist and you're told you have something, that usually happens in the first few minutes, and the next 15, 20 minutes, no offense, the patient and family don't hear anything else. And that'll be me if I remember it. I mean, there's no way I'm going to remember anything past whatever they tell me. That just shifted my whole world. But wouldn't it be great, though, if someone had a link that was identified for them, where AI can help answer their questions and gets information back from them that's given to the care team to help create the right message for them? That'd be incredible. That would be world changing, giving people back time to not be burdened by the administrative, burdens of healthcare.
So it's almost personalizing their treatment plan. We actually do videotape, on your phone, our visits, so patients actually can refer to the conversation later. Because you're absolutely right, Steve. After they hear that they have a diagnosis of cancer, they don't hear anything else. And all that important information is lost. Let's talk a little bit about AI in record abstraction. Remember when we started using algorithms to oversee our ICU care? We identified that there were some early warning signs, so we could anticipate when somebody might be unstable before they actually became unstable. What do you think about using AI for chart abstraction and kind of identifying things that are very difficult for our chart abstractors currently to pick up?
I think that'd be ideal. Right now, as you know, we spend a lot of administrative time either at the physician level, NPPA, coder, biller, trying to find those magic words that people are looking for in order to determine your risk stratification and thus your billing, and even quality metrics at the back end. It shouldn't be a game, right? We should be able to say, I remember early on as a young doctor when I kept saying urosepsis, I got the nasty gram saying, no, you mean UTI with sepsis. Those very specific words. So AI should be able to help with that. Should be able to take the human element out of it, let us practice and talk, and then make the crosswalks so that it gets categorized the correct way and in the correct format. To me, that's yet another easy lift. And I've seen the products. I've been demoed by some of our younger medical staff who have me as the patient and they're the doctor, and we just have a conversation and they hit a button and it can either generate a consult note, the H&P, the SOAP note, and it's better than anything we could have delivered or dictated. And so, we do think there's a way coming that'll make it more compliant and hopefully, again, get some of the red tape, some of the administrative burden out of healthcare.
Yeah. Let's talk a little bit about safety and how we create community partners, because patient safety is of great interest to people in our communities. And you live in a community like mine that people come up to you in the grocery store and in the coffee shop. And safety is probably one of the number one things that our patients worry about. How do you actually engage the community so you have internal and external partners that are working on safety across the community?
Yeah, I will take an example in the behavioral health addiction medicine realm. When I was a young ER doc here again decades ago, the construct in the community for behavioral health was very strong, and they asked us to only take care of inpatients and IOPs. And today, all of those community partners are under duress. We actually surveyed them about 2 years ago on the pediatric realm, trying to figure out how we bolster more resources for people who need help in either mental health or addiction medicine services. And I'll just say that everybody needs more help. And so we convened from that discussion a small conference that is now an ongoing symposium. where we try to bring all our partners together to discuss this openly. How are we sharing patients? What's the best way to go forward? Where should we go speak to the community? Who's our audience? And so that's one small example of taking a piece of what we have to try to do more with it. It's not surprising that was spurned by the adolescent mental health crisis that's sweeping the nation, that's also linked to suicide. So that was sort of the call to arms for that. But I take that same paradigm, and that is sort of how we go out there to meet people where they live, whether it's behavioral health, CHF, COPD. There's a lot of community partners that we need to intersect with in order for the people to have the care they need, because we can't do it all alone.
Yeah, especially in rural America, we figured out that our external partners are really important in actually keeping our community healthy and keeping our community safe.
Right.
I want to thank you, Steve, and I want to apologize to our audience for having laryngitis today. But Steve did most of the talking, and I thank him for that. We appreciate you sharing your valuable expertise and insights. Until the next time, thank you, everyone. I look forward to seeing you at the next month's Leadership Dialogue. Thank you very much from rural Hanover, New Hampshire to rural Augusta, Maine.